Welcome everybody to our webinar on the use of topical carboxy delivery in aesthetic medicine for hair loss and other indications. So I want to thank you all for attending, and you may be watching live or you may be seeing this sometime in the future. In the very last slide, I'll give you some instruction on where to send your questions, but during the live session, please send in your questions as the webinar goes, and we'll be sure to answer those for you. Now, I'd like to start by introducing both of our presenters, myself included, but first let's start with Dr. Gino Marcovici. Now, before I begin, I also want to caveat one other thing, which is tonight what you're really being presented with is a combination of technologies with a specific focus on hair growth, but from each of us, what you'll have is basically a presentation on our expertise in the two technologies that were brought together to achieve the goal of hair growth. And on the first part, we'll look at the use of carbon dioxide or topical carboxy delivery or therapy in aesthetic medicine, and then we'll couple that with a review perhaps for some of you on hair growth and some of the mechanisms and background science. And then we'll take a look at when we put these two together, what happens, and hopefully if we're successful at communicating what the science means, how it came together, and what we see happening here, it's pretty exciting. So we're looking forward to reviewing that. And so let me start first with Dr. Gino Marcovici. Now, Dr. Marcovici is absolutely our expert tonight as far as hair restoration is concerned. His education goes back to Columbia, but he's also worked along the way on a number of boards and certifications on anti-aging and regenerative medicine. He's also board certified diplomat with A4M. He has published a number of studies where he has worked collaboratively at a number of institutions, including University of Chicago, SUNY Albany. He's looked at functional genomics. He's also studied and published on phytotherapy research. And so if you boil down all the areas of his specialties, you would say regenerative medicine, anti-aging strategies, nanotechnology, drug delivery, botanical medicine, gene expression, and modulation. For myself, Dr. Sam Nadbala, let me review a little bit of my background because I come from a different pedigree. I have a master's in clinical chemistry, and although clinical chemists don't exist as much as they used to, we primarily focused our efforts on developing a lot of the in vitro diagnostics and techniques that we use today so routinely. And then later, working mostly in industry, I have developed a series of products over time that are used for a variety of solutions to many problems, some rapid tests, some in cryosurgery, and tonight we're talking about efforts in cryotherapy, which is where we would put topical carboxy delivery. For each of us, we would encourage questions about individual areas of science and perhaps other areas that you've seen application. But what we hope you come away with out of this is a number of specifics. Sorry. Okay, so our topics will deal first with carbon dioxide in aesthetic medicine, and we're going to talk about the instrument that's used to deliver that, which is CryoTouch MD. Then we're going to cover hair loss, causes, treatment, the options that have been used to date. And then we'll talk about TrichoCyte, which is the work that Dr. Marcovici has done over several decades, actually after almost 3 decades of work in hair growth and understanding its mechanisms. So for each of us, we always have to disclose. For me, I'm the CEO of CryoConcepts. However, I'm deep into the science and the development of the technology over time. And for Dr. Marcovici as well, he's the Chief Science Officer and the developer of TrichoCyte that we'll talk about during the webinar. Now, as we go through the first two parts, which sort of lay down the science, the third part starts to bring things together where we say, now when we combine these, what happens? And hopefully you understand why at that point. And then at the end, we'll answer any questions and circle back to any of the issues that you may raise during that period. So let's dive in and start to talk. So carbon dioxide in aesthetic medicine is really the first topic. And so let's start at that level and then bring it in into how we apply it today. So carbon dioxide was really one of the first gases that was isolated and used all the way back at the turn of the last century. It was primarily used in areas of cryosurgery. and I'll mention this a couple times as we go through, but I love going back and collecting things. So I found books from the early 1900s that talk solely about using carbon dioxide for cryosurgery. Later, of course, this was replaced more frequently with liquid nitrogen and nitrous oxide, but it was a staple for a long time, used for a variety of indications, of course, that we still treat today. And then later, in the mid-1950s or so, carbon dioxide's worth in terms of its benefits, especially in aesthetic medicine, were identified. And so people began to go back and look at some of the 1800s information, water baths that we now know contain dissolved carbon dioxide and minerals, and the benefits that were seen. So it really goes way back, first identified in these water baths, but later really refined into what we saw in the 1950s and now what we bring today. Now, I had mentioned the use of a topical carboxy therapy or delivery across the 1800s into the 1900s. And it's really very interesting because what you'll see is that during the 1950s, there was a number of devices that were used to deliver this, and the benefits of that identified. So in the 1950s, there were a couple of devices you can see here. And so the Carbotom was probably the one that was most popular. And this is really very interesting. So again, I told you I really love history and being able to go back and do things. So I actually on eBay some years back found one of these. And so I want to show it to you. This would be the cylinder of carbon dioxide. And then underneath is a reservoir in which I would put a fluid like water that was infused with oils or herbs. And then you could hear the squeak of this. And then I would simply pull the trigger and spray. A larger version of this is also shown, and you could, if you can see this close enough, you'll notice it's all stainless steel. So for whatever person was operating this, I'm assuming an esthetician, they must have had forearms that were huge after time with this. And so this is actually some postcards that were advertisements in France way back when, and you could see Madame Barbier and the advertisements that she had in Paris using the Carbotom for these treatments. Now, there were also publications back then, and so early clinicians started to notice that these carbon dioxide baths affected blood vessels and heart. They caused dilation of the peripheral vessels, and this goes all the way back to 1949 if you begin digging deep enough and looking for these publications. The high pressure of devices like the Carbotom, they said massage the skin and of course exfoliated. Now I can tell you CO2 is 850 psi when uncontrolled like this, so for sure it was exfoliating whatever it was being sprayed against. But again, it was very popular during that period. I suspect during the 1960s, when other techniques like dermabrasion started to come along and microdermabrasion after it, some of these techniques really faded, but now they've been brought back and for good reasons. The Bohr's effect, which is underpinning all of this, is really well established. We know that this change in pH in the presence of hemoglobin will cause the release of oxygen. We know this from the interface in the lungs, but also it's been established that for topical use that this brings benefit. And so there's a number of publications, and I want to make sure I cite some of the ways that this has been proven and used. And so a lot of the research over time has been done using simple chemical reactions that generate CO2 at the surface of the skin. So as recent as 2022, there's been a number of publications that have focused on looking at fracture repair as one example, and the demonstration of angiogenesis when transcutaneous carbon dioxide was used as part of the study. Diabetic wound healing is one that you may be familiar with. Also, a really interesting one was oftentimes you may be aware of scarring pain that patients have after surgery, and the lack of circulation around the scar is one of the things that leads to this pain. And there's been a number of studies that look at transcutaneous CO2 as a way of relieving this, and that was done both from patient perception as well as with dynamic MRI. So a number of technologies have been used to document this, and even in animal studies that have looked at cell markers, VEGF, and also mitochondrial increase, all say that topical CO2 brings about benefits. And so when we look at technologies, especially in aesthetic medicine, something that is immediate, something that is non-invasive, something that can be applied to any skin color, any sex, male or female, then topical carboxy delivery does that. And so I said I would mention the instrument that was used in our studies, and that's the CryoTouch MD. So this is a device that uses a reservoir of CO2, and you could see the handpiece, the back of it here, to which a cartridge containing a formula is placed. At the tip, there's a mixing of the CO2 and the formula, which is applied under light pressure to the surface of the face and delivers it basically in a way that allows the CO2 to transcutaneously work, as well as encourage delivery at a low temperature of the formula. Now, I should also point out this never goes below -20 degrees centigrade. That would be cryosurgery at that point. So it hovers just warm of that so that it's cold but not uncomfortably. If you look at the ways that this can be used, you know, and I summarize some of the actions that come out of the literature as well as our own work, it ameliorates pain. We have oxygen release, we have increased capillary flow, neoangiogenesis, and fibroblast stimulation. All have been documented in the literature using topical carboxy delivery. So the definition I use here, and you could see the image to the right of the slide, that's essentially what it looks like as it's being applied to the surface of the skin, in this case, the face. Now, the additional formulations, and we're not going to dwell on this, it's just to give you some breadth of how this works. So now think, okay, when I use a topical carbon dioxide, I get this increase in blood flow, I get an increase in oxygenation. So any place I start to use it brings benefit to the patient. So simple anti-aging formulas improve the overall look and appearance after the treatment. Pain and redness reduction, certainly after other ablative procedures. When I use the right formulation plus carbon dioxide, I see an immediate reduction in pain and redness as a benefit. We'll talk about hair growth in just a moment in detail, and of course, a plumping effect, increase in circulation. So overall health at the surface of the skin improves when I deliver my formulation, whatever that may be, with carbon dioxide. And that's the underpinning for the contribution that's made by the CryoTouch and the background technology of carbon dioxide. So now let me turn over the podium to Dr. Marcovici, and Gino will lead us through this next section specifically about hair and the TrichoCyte story. Gino, to you.
Thank you, Dr. Nivola. That was really excellent so far. Just to briefly touch on a little bit more about me, I come by this field honestly. My mother was a manicurist, my father was a hairstylist, and so I kind of feel sometimes like I have perm solution in my veins. I grew up in a beauty salon, more or less, and I've always been fascinated with hair. And really, when my own hair started to thin a little bit, it became deeply personal. So from that, my academic background is molecular biology. And interestingly, I spent 10 years in clinical medicine as a partner in a surgical hair transplant facility in Denver, Colorado. And one of the real challenges that we faced in mapping out a restoration plan for our patients was not just restoring the hair that had been lost upon presentation, but knowing in the months and years ahead, are we going to be chasing a receding hairline, number one? And number two, are we going to run out of donor area that is our reserve to move the hair from the back to the front? It's like moving grass from your backyard to your front yard. Are you going to have enough? And we were aware at the time of course, the drug minoxidil had been released, but there were significant side effects associated with that drug, discomfort and other things. Finasteride came on the scene in the early 1990s, so we tested that drug in clinic as well. But feminizing birth defects, gynecomastia, suicidal ideation, among other serious negative side effects, were the caveats that gave us pause before recommending the approach to our patients. And I happened to be attending in the early 1990s a lecture given on some natural compounds that were being used in Europe to treat polycystic ovary, another disorder that shares striking homology, both biochemically and genetically, with pattern hair loss. And it seemed that some of these compounds, some of the substrate, could be applied to the treatment of androgenetic alopecia, or common pattern hair loss. So we had a clinical population, that was raring to go, that was very happy to let us try out these primitive baseline formulas and see how they worked. And sure enough, they were working at least as well as some of the drug therapies that we had tried at the time. And that kind of gave us the foundation to build from there. This was in the mid-1990s, and we've been at it, until today. So let's talk a little bit about hair growth and then hair loss and kind of lay the landscape there. So in terminal healthy hair, scalp hair, we have three phases within the hair cycle. The first is the anagen, that's the longest cycle, typically 2 to 5 years of active growth. In catagen, there's a transition to the resting cycle, which typically lasts about 90 days. And then we see a return to anagen, where you'll have the same rate of growth and the same caliber of hair in healthy hair that's unaffected by the phenotype, unaffected by pattern hair loss. So if we move to the hair loss overview, we find that in both males and females, by far the most common form of hair loss, the most common presenting phenotype is androgenetic alopecia. And that's over 95% of those who will come into your clinic complaining about hair loss. Males typically begin to experience loss of hair 25 to 30 years of age. Females a little bit later in life, either just prior to or as part of menopause. In terms of population in America, conservatively 40 million men, 20 million women. Extrapolate that out worldwide, and you're talking about 300 million males, 150 million females. So one of the early pioneers in hair transplant surgery, Otar Norwood, came up with a handy chart to describe, to show the progression from healthy, unaffected hair all the way through to the most severe form of pattern hair loss. And that scale goes from 1 to 7. And from 2 to 4, the loss is typically noticed more in the front. As we get progressively more 5, 6, and 7, the front baldness will meet the crown bald spot, and you can end up with just a very thin, in severe class 7 baldness, you'll have a very thin rim of supraauricular and lower occipital hair that persists. But aside from that, the loss is complete. And then we can go ahead. I think we can go to the Ludwig scale here, actually.
My mistake.
No. Dr. Eric Ludwig in 1977 came up with a scale to represent hair loss in women, androgenetic alopecia in its female presentation, stage 1, 2, and 3. In stage 1, even though a woman may have lost up to 50% of her density, she can still usually camouflage that by wearing different hairstyles and even cutting her hair perhaps a little bit shorter, doing different things cosmetically to disguise what's happening. Pharmaceutical treatment options for women include minoxidil, spironolactone can be tried. In stage 2, Ludwig female loss, the ability to disguise the phenotype is much more difficult. At this point, some females present in hair transplant clinics, and hair transplant is successful in some of these women, but the practitioner needs to be extremely careful, because in female pattern hair loss, the pattern can extend down into what would be in a male, the healthy donor area over the ears and in the back of the head. And so if you run out of donor, if you start transplanting hair that is eventually going to fall out, you're not doing a lot of good for your patients. Stage 3 is considered the most severe form, and here we see women that are wearing replacement systems, basically wigs. We should probably pause for just a moment in considering female hair loss to recognize that there are comorbidities that will occur in women that you won't see in men. And these include, as we've mentioned earlier, polycystic ovary, hyperandrogenism, and certain forms of thyroidopathy. So as a clinician, you want to be aware of that and test accordingly. And next slide, please. So we mentioned that pattern hair loss affects more than 9 out of 10 patients that will show up in your clinic. And interestingly, androgenetic alopecia is what's known as a complex trait polygenic disorder. Now, there are monogenic hair loss disorders, and they include autosomal recessive hypotrichosis, lysosomal storage disorders, mucopolysaccharidoses, and other really rare forms of hair loss. But again, the most common form that will present in your clinic will be someone who will be diagnosed with androgenetic alopecia. As a polygenic complex trait disorder, it has always struck us that treating this disorder with a monotherapy really limits the ability to rescue the phenotype in any meaningful way. And I think the results that one sees with finasteride and minoxidil support that hypothesis. So let's go on to the next slide, please. We started with a simple understanding that pattern hair loss is in large part mediated by the conversion of testosterone to 5-alpha dihydrotestosterone via the enzyme 5-alpha reductase. That's been known for a long time. And finasteride capitalized on that, and to a lesser extent dutasteride, which goes after both flavors of 5-alpha reductase and blocking that enzyme from converting T to metabolite DHT. But we also thought that there were some other interesting, and I don't necessarily want to call them low-hanging fruit, but there were some other factors that were influencing onset and progression in pattern hair loss. And so we looked at things like microinflammation in the hair follicle and tested compounds that could ameliorate that factor, and we saw improved clinical results. By the same token, we looked at the JAK-STAT pathway and found that inhibiting that one via other compounds also seemed to add to the benefit clinically that we were seeing in our patients. One of the things, and I guess we can go to the next, well, no, we can stay on this slide. We can, sorry.
Okay.
Sorry, Dr. Eagle. So the last thing that, or the last target that we identified was we understood that many macromolecules, vitamins and such, are either largely excreted in the urine or they're metabolized via the cytochrome pathway in the liver before really doing much benefit in the target tissue, in this case, you know, the scalp hair follicle. So we looked at various means to nano-enable or invaginate our active bolus in delivering that therapeutic bolus to the hair follicle to see if we could improve our results. And in fact, we were able to do so. A 2020 published study reflects our experience in that regard. And if we can go to the next slide. Today, as clinicians, you're likely hearing a lot about PRP, platelet-rich plasma, and exosome therapy, and for many different indications. And in our view, the problem with a shiny new hammer is that everything starts looking like a nail. Here we have examples of results that are, I guess, being represented as success stories. The top photos you see are exosome therapy, excuse me, or PRP therapy, and the bottom photos represent before and afters of exosome therapy. And we would characterize these, I think, generously as quite modest results. But again, this seems to be widely used, somewhat state-of-the-art in hair clinics and aesthetic clinics, really worldwide today. And with that, I will turn things back over to Dr. Nipola.
Okay, thanks, Gino. So really from here, let's transition, but there's a slide we need to just stop with and pause for a moment. And that's really the elephant in the room. We have been talking to clinicians for months now about this new approach between CryoTouch and TrichoCyte. And almost everybody goes, where has this come from? You know, what's the basis for this? And as you can see already, there's a deep knowledge on the part of Dr. Marcovici in developing the TrichoCyte itself and the approach using botanicals. There's also an approach on our part at CryoConcepts working on the delivery using the CryoTouch MD. So the question always comes back, which is, you mean I don't need to needle? You don't need to somehow inject? And so there's this underlying principle that we talked about, which is almost this idea of no pain, no gain. And I know that's so true in aesthetic medicine, and everybody would say, well, that's why I use a laser, that's why I do microneedling, that's why I do injections. All of it is just part of getting to the desired outcome. But you know, the real question when it comes to hair growth is pain really a necessity? Must I depend on injury in order to stimulate biochemical processes? Are there side effects that I have to consider, like with minoxidil or finasteride? Do I have to tolerate spotty or inconsistent results? And so we're really challenging this, as you'll see in the results in just a couple minutes. And what we'd like to just say to everybody that's listening is, really the biochemistry, while there's still more to learn, there is a lot that's known, and clearly this is a polygenic disorder. And when you look at the approach as described by Dr. Markovici and myself, what you see is that there is a way to deliver a pain-free treatment and without the negative effects that can come with many of the current therapies. So the results will speak for themselves, and certainly we're early in this collaboration. So we really appreciate you listening to the story and evaluating for yourself whether or not you fall into the existing paradigm that without pain it's not possible to get the gain, and maybe we'll convince you a little bit different approach is possible. So now let's start to bring this together in the remaining time and talk about hair restoration, and we call it TrichoCyte powered by CryoTouch MD. And what we're really, first of all, stepping back to do is remind ourselves that Dr. Markovici in his research has already published the use of these botanicals for hair restoration. The images that you see on this are day 1 and day 270, and one of the subjects that was used in a publication that looked at the nano encapsulated TrichoCyte materials, but delivered by hand daily to the patient. And so typically this is a pump foam that is applied to the scalp, and then a nutraceutical tablet that's taken daily. In this study, 270 days were necessary to get the results that you see. What we did in our study was something a little different. So the hair study protocol that was conducted last year, and we're continuing this work now by looking at some basic biochemical markers as well as additional clinical work, is we designed a study where we filled cartridges with a concentrated formula of TrichoCyte and delivered that to the scalp once a week for 12 weeks using the CryoTouch system. CryoTouch, as you would expect, stimulated blood flow, increased oxygenation, and then in addition to that, patients continued an at-home regimen of the serum, the foaming serum and tablets, so that in essence what we got is a mass action equation, if you're a chemist by training, that basically was pushing the TrichoCyte formulation forward as much as we could in this clinical regimen. And after the 12 weeks, what we started to see was the following. These are some of the male patients that were part of the study. And so these patients aged and ranged from 30 to 50, and each of them saw significant hair growth during the course of the study. So this just represents those that completed the 12-week program. And after activation, it's worth noting that you still have to continue the regimen at home, but what you're doing with the combination of CryoTouch plus TrichoCyte is boosting the metabolism at the surface of the skin, basically bringing about a faster course of action. And so overall now, as we bring together the two technologies and the basis for TrichoCyte plus the basis for CryoTouch, you see the results in basically the hair restoration and growth that was seen here. So as we start to then conclude, we can look at this. And so I added one more picture here just earlier today as we were prepping for the webinar. And this is an interesting story. So this is a 30-year-old engineer in our offices, and you can see on the left him starting to recognize his loss of hair. And so he volunteered his hand when we said anybody in the office wished to be treated. And so after just 6 weeks of treatment, you could see on the right the results that we're seeing. Now, there's videos and other things that are available on the website to show how exactly the application was done. But the protocol that I talked to you about in a couple slides earlier was followed here, where it's once a week treatment with CryoTouch, and then the at-home treatment daily with the nutraceutical tablet and the foaming serum. That is what you see here. So hopefully, as we conclude, you recognize that while we understand AGA is polygenic, it's complex. And so the combination of therapies that we talked about today are bringing about significant improvement in a much quicker time than one alone. Second, this is safe and effective. There's no chance of the side effects that other technologies or other modalities have brought about, and there's certainly no need to do microneedling or any other sort of invasive procedure. And so really what we hope you can appreciate then is our challenge of the paradigm that no pain, no gain. And really in this case, all natural materials properly targeted, properly delivered, and adhered to by the patient as far as the regimen can bring about the results that they're looking for. And you know, we were happily surprised by the results of our early study, and we're going to continue that research. We want to understand more of the mechanisms and where we might continue to improve. So as we wrap up, we want to say thank you. I'm going to address questions in just a second, but over on the right are an email or website that you can certainly reach out to us with questions afterwards. And so let me go over here to our list of questions that are being submitted now. So question number one is this effective on females with fine hair? They may not be losing their hair, but want thicker, fuller hair. Dr. Gino, you want to answer that?
At first blush, if the hair is fine because it's fine, not because it's being lost due to pattern hair loss, I don't see a benefit in. It's not something that we're trying to change genetically programmed hair from one state to another if it's not part of the disease phenotype, pattern hair loss. So I wouldn't suggest that we're going to accomplish much there.
Okay, fair enough. And then we have a second question. Sorry, I need my reading glasses. Are there any gender differences with the approach or outcomes? Again, Dr. Gino?
Well, it's still early in the game, but because the biochemistry and genetic precursors are strikingly similar in both genders, we see no reason why outcomes should be any less robust in one sex versus another.
Fair enough. And again, we continue to build out the body of data and information about this combination of technologies. If you have any further questions, you can text them in at this point, or again in the future. Feel free to contact us and we're happy to answer the questions. Let's see. Okay. Here's the next question. How many clinics who offer FUE have adopted CryoTouch? I can't imagine a patient who is simply thinning choosing surgery over this painless treatment. So we're early in this. There's about a dozen clinics now that are up and running with this treatment. And so results are coming in, plus others that we're treating. It's really been a very interesting experience with this. And I really like this story. I'm not going to call out by name, but one of our sales representatives who really has fallen in love with this treatment, he treated himself at home because he has one of the units and some of the kits. And what he's been doing is going out, because his hair started to grow back. So he's been going out to all of his accounts and basically showing them, here, look at my head, and here's my picture before, as a way of doing this. So as we said, we're early in this, but the data continues to come in positively. And so we're starting to talk about it and promote it as we are in this webinar. So we hope you'll consider that. Now there's another question. Can this be used with patients who have lost their hair because of chemotherapy? Gino, I'll turn that one over to you again.
You know, Dr. Niebela and I have been talking about that, and while we have some theoretical, hypothetical ideas as to why perhaps there may be some benefit in that setting, it's our view that any patient undergoing chemotherapy or planning to undergo chemotherapy involve their treating physician, their oncologist, in helping to evaluate the utility of this approach in that setting prior to just coming on board and giving it a shot.
Yeah, it's a really common question that we're getting all the time. We tend to be conservative, and I think over time we'll be able to give better guidance on that. But really, that whoever that chemo patient is, they really need to talk to their clinician, and time is, you know, everything. We would love to be able to help, and so I think over time you'll see more data coming out about that. Other questions that you may have? Okay, so Dr. Gino, thank you very much for presenting. And then to everyone who's online and will be watching this in the future, thank you so much for taking the time to see our content. And again, we'll see you again with our next webinar. Thank you.
Thanks.